Welcome back to another episode of The Interesting MD. This week is going to be the first of a 2-week series about doctors considering moving to Canada. I have Dr. Paul Hertz. Welcome and thank you so much for coming.
Thanks for having me, Rob. It's good to see you again. The government is in charge of paying all physicians their fees. What happens is each specialty will have a range of fee items that they can bill. So, for internal medicine, it would be like a consult fee or a follow-up visit in the hospital or a follow-up visit in your office. Each individual item has a certain value attached to it. And what happens is you collect all the items that you do on a given day. You submit that through the system to the government. And, every couple of weeks, the government sends you a check accounting for all your money. The other thing about the Canadian system, there's complete portability between provinces. If I'm eligible for a license in British Columbia, I am eligible for a license in Nova Scotia or Saskatchewan or Ontario.
Welcome to the Interesting MD podcast, the show about what doctors do when we aren't seeing patients and how this can help us find balance and prevent burnout. I'm your host, Rob Beck. Welcome back to another episode of The Interesting MD. This week is going to be the first of a 2-week series about doctors considering moving to Canada. I have had a lot of conversations recently with people who have reached out to me or have been put into contact with me about US trained physicians who are wanting to move to Canada. This show is not about politics, and that's not what it is, but there are a lot of reasons that you might want to consider moving to Canada if you are a US trained physician. I can definitely attest to that, but they are two very different healthcare systems and life is very different. So I have kind of an expert on being a doctor in not only just being a doctor in British Columbia, but also in the inner workings and kind of an expert on some of the inner workings of the Canadian healthcare system here in British Columbia. And I have Dr. Paul Hertz, who is here. He is a physician in North Vancouver who was actually really instrumental and helpful in Andrea and I getting our feet settled and just getting firmly planted while transitioning over. So I will give it over to Dr. Paul Hertz. Welcome and thank you so much for coming.
Thanks for having me, Rob. It's good to see you again. Always a pleasure to introduce new doctors into the healthcare system.
It was a very interesting time. So thank you so much for
absolutely. I know there's a lot of interest from all around for people coming up north, possibly for the first time in quite a long time that we've had kind of a brain gain as opposed to the brain drain that's been going on, the last several decades. But pleasure to be here.
Thank you so much. Again, can you just start off by telling us a little bit about you, where you're from, where you went to school, where'd you do your training, where do you live now?
Yeah, absolutely. So based on the background here, you may have guessed that I'm from Toronto. That's a puzzle of the CN Tower and the Sky Dome. I grew up in Toronto, which is where my family still lives. I did undergrad there and then went to Queen's University in Kingston, which is also in Ontario, for medical school. And then after medical school, I came out to BC to do my internal medicine residency and just never left. For anyone that's been out to BC, that's kind of a common occurrence. I think people that move out here realize how amazing it is to live in a place with beautiful weather, with mountains, with ocean, and just a really high quality of living. So I've lived in BC now for the last 15 years or so. And I currently work in North Vancouver, which is technically a suburb of Vancouver, but it's just across the bridge, just over a short amount of water. So
it's a very short sea bus ride away.
Yes.
For those who did not know, like I did not know, it is not the letter C, it's the SEA bus. It goes across the harbor there.
Yeah, it's a tiny little ferry that is included in kind of municipal transit, just like the subway is. So it's $3 ride over the water, just gets you right to downtown. And I don't know if you saw there was a Globe and Mail article ranking 500 plus cities in Canada, and it was rated the number one most livable city in Canada.
Wow, I did not see that one. It's pretty great. And yes, when you do come to kind of the Vancouver Island area, especially I'm sure that if you're from other parts of Canada and you suffer through the winters, and then you come and you're like, hey, I didn't have to dig out of my, I didn't have to dig out of snow.
Yeah, exactly. I mean, I think I shoveled twice this year. And otherwise, it's a very balmy kind of stays above zero or above
32, 32,
Yeah.
32. Yeah. So you live in North Vancouver, the number one city in Canada. And so you work where?
So I work at Lionsgate Hospital, which is the main hospital here in North Vancouver. It's a relatively large community hospital. There's some kind of academic teaching, but it's mostly, serving our community as well as a few other local communities like Squamish and Whistler and a few First Nations communities up north as well.
And you guys just got a new tower. Is that open now? Is that
We
what I
did,
heard?
yeah. So they built a brand new tower with 200 private rooms and new operating rooms and a whole bunch of other fancy things. And that opened about a month ago. So we're just it's still fresh.
Still fresh. You can still smell the new paint.
We can.
Awesome. So the reason that I did want to have Paul on is because not only is he just awesome and does a lot of really, really cool things, and some of that we'll talk about later on, but Paul has quite a few leadership roles in British Columbia in the healthcare system here. And he would be able to explain what higher level views starting off and then moving on to some more granular details about what a single payer healthcare system for any American physicians. This is really important to know if you want to start thinking about moving here and start thinking about practicing in Canada. And so Paul is going to give us a bit of an overview here, and then we can talk about some specifics later if that's okay.
Yeah. Absolutely. The basics of the Canadian healthcare system is that there's a single payer, which is the government. It's the provincial government. Each individual province has their own kind of healthcare system. It's ultimately funded by the federal government, but since Confederation, healthcare has been a provincial jurisdiction matter. The government is in charge of paying all physicians their fees. What happens is each specialty will have a range of fee items that they can bill. So, for internal medicine, it would be like a consult fee or a follow-up visit in the hospital or a follow-up visit in your office. And so each individual item has a certain value attached to it. And what happens is you collect all the items that you do on a given day, you submit that through the system to the government, and every couple of weeks the government sends you a check accounting for all your money.
So let's just stop there, because American physicians are trying to figure out how exactly does that happen. I submit my bills because this is pretty amazing. This is literally how it works. I submit my bills on an app. There's a private app here that I pay a small fee to every month, and I enter in my charges, and they submit that to the government. And literally every 2 weeks, I get paid. And that is not how it works in the United States. There is no back office that really has to deal with any of this. Your patients do not get an explanation of benefits. They don't get a charge. They don't have a copay to come and see you. That is not what it is. It is literally they come in, they have paid their taxes, they have signed up for, they've been enrolled in the healthcare system, and they come in, you see them, and you put in your bill, and that's it.
Yeah, it's super easy. It's even simpler than that from the patient perspective. They show their health card, and kind of that's the end of it. They never have to pay anything. They never have to worry about getting a bill. And on my end, it takes me perhaps 5 minutes per day, sometimes less, to input all my billings and submit them through. I'm sure I use the same app as you. I submit my billings, and then eventually I get a direct deposit in my account 2 weeks later. There's no fighting. It's a very, very straightforward process.
Yeah, same for me. So when you want to enter in a new patient, I'd enter in the patients manually. I don't know why. I think that you can just take a picture of their information, and people do that much easier. I don't know. I still do mine manually. I don't know why. It just feels more accurate. I don't know. But that takes me about 30 to 40 seconds to do. And then you have a very small list of items that you could do, right? There's, is it a high level consult, a low level consult, a limited consult? And then it's either a follow-up visit. And, for internal medicine, there's kind of internal medicine diagnoses, right? That we would get, that we have the eligibility to bill for, but that's never really a problem. So it is literally that easy. Even on really, really busy call days, it never takes more than 5 minutes to do all the building. 10 minutes, absolute worst day ever.
Yeah, so
And
it's pretty straightforward system. Each province sets their own fees, so it'll be different from province to province. Every province is going to have an internal medicine consult, but in British Columbia, we additionally have a complex internal medicine consult, which pays us a little bit more. At the end of the day, each province sets fees that are negotiated with each individual specialty. There's a representative committee and a leader of each specialty. So in BC, I'm actually the head of our specialty, the general internal medicine. Me and the executive council that's been elected from our membership negotiates with the government to set our fees and determine kind of where to most appropriately put our money that the government kind of divides out to us.
fantastic. And thank you very much for all your hard work. I know that you guys have been putting in a lot recently, and that's not the world's greatest job, I'm sure.
I do it. I do it for the love of the specialty and fellow doctors. I certainly don't do it for the compensation attached to it, which is minimal. So.
Yeah. And that's true for all the specialties, right? Like, I mean, the surgeons, the pediatricians, the psychiatrists, the family medicine doctors, like it's pretty uniform too, right?
Yeah, exactly. There's a fee schedule that exists for each individual specialty. Pediatrics has their own codes, and general surgery has their own codes, and anesthesia has their own codes. As a group, as doctors in the province, will sign a contract for 4 or 5 years, wwhereas Doctors of BC, which is our overarching kind of advocacy organization and our negotiating body, will negotiate with the government and the Ministry of Health, and they'll give us some money, and then that gets divided by specialty, and then each specialty then divides the money how they see fit in terms of creating new codes or changing up existing codes or adding value here or there. So it's a fluid system.
And again, that is for all doctors. So if you're an internist in Prince Rupert or wherever, like very, very far north in BC, it's the same as if you're in Victoria, North Vancouver.
Yeah, pretty much. I mean, so the fees are always going to be the same. A consult in Prince George in northern BC is going to be valued at the same as a consult in Vancouver. There are some additional bonuses for people working in rural and remote areas, just to attract people there. So there's kind of incentives on top of the billings, but the billings are the same throughout the province. Regardless of a big hospital, small hospital, big city, small city, everyone's getting paid the same.
And again, for anybody who's looking for any of those jobs, that if you want something a little bit more remote or you want to just try something like that, there's pretty good incentives to go to some of these places.
Yeah, I mean, the smallest communities have incentives of 20, 30%, which is pretty generous.
Yeah, that's pretty generous, especially, the decreased cost of living. I mean, it's probably much cheaper to live in my apologies for the geography, Prince George, north, than it is to live in downtown Vancouver. I'm sure that there's a...
Well, I mean, it's cheaper to live almost anywhere than it is to live in downtown Vancouver. But
I think there's like 2 places in the world that it's more expensive than, but fair enough. So that is how that works. Anything else? So we've got the compensation part of that, or at least that's how people get paid. What about the hospitals and the hospital system? So in the US, we have a lot of hospital systems. And so you can have multiple hospital systems within a city. But when you go from the provincial level, like what's the next level down?
Right. Okay. So you have the provincial government and the Ministry of Health, which kind of controls the overall budget. And then the province is split into 6 health authorities. And health authorities are kind of these umbrella organizations, which usually have multiple hospitals in their purview. So my hospital is part of Vancouver Coastal Health, along with Vancouver General Hospital and Squamish Hospital and a whole bunch of other sites. And from that level, they're in charge of large capital expenditures like getting a new CT scanner or opening up a new oncology clinic or bringing in a new dialysis center to a city that didn't have one or something like that, or building a new tower at my hospital. So they do that through a combination of fundraising from the public and then government funds.
So I'm in the Vancouver Island Health Authority, and that kind of covers like the 800, 900 million people, whatever, 800,000, a million people. And then that's where all of those. So that's where the capital expenditures come from. And what about hiring, firing, or, well, I guess nobody really gets fired, but like, what about the...
Hiring and firing is a bit interesting. I mean, technically we're not hired by any hospital because the hospitals don't pay us. The government ultimately pay us. So in Canada, we're all just considered independent contractors. So the hospital gives us privileges, which allows us to work in their hospital system and, use their resources and things like that. But they're not really in charge of hiring or firing. So each hospital will have a department head and a division head, and I'm also the division head of my hospital in the internal medicine department.
Everybody sees why I have you on here. Right?
So we're in charge of kind of advertising and recruiting people. And then we kind of decide as a group, do we want to bring more people? Do we need to bring more people? The answer to both questions currently is very much yes.
An emphatic yes.
An emphatic yes. And then, we basically tell the hospital to provide privileges to people that we want to bring in and be a part of our group. And that's usually fine.
So the hiring process really is, or process, if I'm speaking Canadian, but the hiring process really is, you guys post a job?
Yeah, we post a job and, we talk to people, we can do some interviews, but it's very much like for the non-surgical, non-procedural specialties like internal medicine, very, very much physician driven. If you have someone like a surgeon who needs operating time or special equipment, stuff like that, then you do have to work a bit with the hospital and the health authority to make sure that there's enough kind of resources available. But for something like us, it's literally just saying like, we need more people. So we post something, we advertise, we talk to people and we bring them on.
That's easy.
It is pretty easy.
Yeah, I mean, it actually is a pretty painless process, that part. And so with the individual hospitals, how do things work on kind of the individual hospitals? Are they kind of islands themselves, or are they, kind of separate little areas, or are they just they're all part of a bigger system, I guess. But each hospital, like there's two major hospitals in downtown Vancouver, right? So there's Vancouver General and there's St. Paul's.
There's some other smaller ones. There's Mount St. Joseph. UBC has a hospital. I mean, Richmond Hospital isn't all that far. There's Burnaby Hospital, which is pretty close. But yeah, certainly the big ones would be St. Paul's and Vancouver General.
Okay. Yeah. So I don't practice in Vancouver, and so I don't know about any of those, and I haven't gone down to the Lower Mainland for any of that.
Yeah. So, I mean, I would say most hospitals run fairly independently. There'll be a group so for internal medicine, there'll be a group of physicians that share in the call responsibilities and kind of the outpatient referrals in that local community. There are certainly physicians that work at more than one hospital if kind of they're close geographically and however they want to set their schedule up. But most physicians will work in one place, and the groups are, fairly insular, and yeah, they do it that way, I guess.
Yeah. I mean, I work in 4 different hospitals at the moment. So I work predominantly in Nanaimo. That was kind of its own standalone thing. I work in Victoria at the Royal Jubilee and Victoria General. Those kind of work hand in hand. They're kind of considered the same entity. And then I also work at Saanich Peninsula Hospital some, and they all kind of seem to be standalone underneath the health authority. But in the US, there are huge healthcare systems. And so one hospital operator may run, like the one that we were a part of, our division ran 13 hospitals kind of in the region. And then right across the parking lot, there was another hospital system. And then 10 blocks away was another hospital system. And so there was a lot of competition. And that's not so much how it works in Canada.
No, it's very much regional. And like if hospitals happen to be close to each other, then it's common that people will work at both sites, or just to make that work. There's not, again, I mean, I think, correct me if I'm wrong, but in a for-profit system, there's kind of inherent competition for the same patients. Mm-hmm. Whereas here, ultimately, at the end of the day, there's one there's one entity footing the bill for everybody's healthcare. So there's no real competition like, oh, you have to come to my hospital versus you have to come to my hospital. Like that mentality just doesn't exist. You just go to whichever one's physically closest to you.
Yeah. And anywhere in the province, it's all kind of the same, right? I mean, we can all, for the most part, see each other's records, and that each of the hospital systems has a different record system, or some of them do, some of them don't. I think that we share the same one, but there's also a provincial system, just explaining this to other people. And, but there's also a provincial system that everything gets uploaded to. And so if I have a patient who comes to the island from the interior of BC and Kelowna, I can actually see op reports, I can see echocardiograms, CT scans, I can see all of that information on this portal that we have access to. So makes it a little bit easier and helps to cut down on duplication and helps with communication as well.
Yeah, absolutely. I mean, you can see all lab results at any hospital in the province. You can see all imaging tests. You can see, inpatient consultations and operative reports and all that kind of stuff. And it really makes things so much easier. And you're right. I mean, just avoids duplication of work because you can't see something. It's all kind of right there for you.
Yeah, that part is nice. Okay. Is there anything that I'm kind of missing out at this point about things that people should know, or details about what, to this point anyway?
No, I mean, I think, yeah, just in terms of, working, I mean, it's pretty fluid, because you're not hired to a specific job. There's a lot of independence. You can move around. You could work at one hospital exclusively. You could work at multiple hospitals. You can transfer between hospitals. You're licensed to practice medicine, and if a hospital will give you privileges, then you can work there. Or even if you have privileges, you don't have to work that. You know what I mean? So
yeah,
there's a lot of mobility, which is really nice. A lot of people move around, like you guys were here, and then in Nanaimo and Victoria. And the other thing about the Canadian system, which I don't know if it's the same in the US, there's complete portability between provinces. So if I'm eligible for a license in British Columbia, I am eligible for a license in Nova Scotia or Saskatchewan or Ontario. You have to apply for it, but it's just a matter of, it's just currently, they're working on that, but it's just a matter of paperwork. There's no extra exams to write. Like if, I trained in Ontario partially and in BC partially, and I used to work in both provinces, as well as in the Northwest Territories. And licensing, just there's no extra exams or anything. So I think that's another huge benefit of being in Canada. In the US, is it a national licensing, or is it by state?
Each individual state gives licenses, just like your provincial health authorities, like your provincial licensing bodies. But yeah, so we'll all take, like for internists, the American Board of Internal Medicine. So we're all ABIM certified, or your, College of Pediatrics, or, OBGYN, whatever. So you get a national licensing, but then, yeah, you do need to apply. They are doing some good things in the US now, where they're kind of having a lot of states where they all kind of pool together. And so if you're licensed, there's a lot of reciprocity. So if you are licensed in this state, then it kind of applies everywhere. And I think that was something that came out of COVID as well, when they were looking for locums to come, and they realized how onerous this was. And I know that Canada's kind of doing the same thing about addressing some inefficiencies in the system as well. But yeah, you don't have to sit down and write an exam for practicing in Tennessee, but it's, you still have to go through and do all the things. After we moved here, I got my license in Washington, just as kind of like, I don't know, a backup or whatever. So I haven't used it. I called in one prescription there so far. But it was pretty easy because my license was still active in Tennessee. And so it was pretty easy to do that, but it's not always like that there. But and I do know that BC is making it much, much easier for people to get licensed by the BC College. And that is actually who I'll be talking to next week. So that will be, we'll talk more about licensing next week. You're like, I don't want to talk about licensing. You can get hives and start twitching.
It's not that bad. I mean, I think,
yeah.
Just thinking about licensing, and all these docs coming up. I mean, it's been a bit of a transition, and it's an interesting time in BC medicine, just because there are some important differences between internists trained in Canada and internists trained in the United States. And I mean, I think that's become quite relevant recently.
Yeah. So, I mean, like, let's talk about that. That's, so tell us what a residency in, or what training looks like in Canada.
Okay.
for internists. Let's talk about internist. And
So let's talk about internists. I think it's probably similar in pediatrics, but I am not a pediatrician and I have not treated a patient under the age of 16 since I was a medical student, despite all my friends sending me pictures of their child's rashes. I don't know if you get that a lot as well, but it's always a kid's rash. Yeah.
Yeah. It's, for us, it's just like all of our kids' rashes or their friends' injuries. This is awesome. Last year, we actually had a kid that came over here because his brother threw a wall plug for his iPhone, and his younger brother threw it at him and it stuck in his scalp. And it was like a 1 in a million shot. Yeah. So that was probably my last under 16 patient being treated.
So after medical school, which in Canada is either 3 or 4 years, depending on the school, the majority of medical schools in Canada are 4 years in length, but there are a few that are 3. So after that, all internal medicine residents will do 3 years of internal medicine, which we call the core internal medicine years. Mm-hmm. After you've done 3 years, you are not eligible to do anything. You cannot be an independent doctor. At this point, there's a secondary match process where either you will match into a subspecialty, cardiology, GI, respirology, hematology, whatnot, or you can match into general internal medicine. So general internal medicine is an additional 2-year residency, so 5 years in total, where you focus on, general internal medicine and perioperative medicine and obstetrical medicine and all the weird and wonderful things that come along with internal medicine. Currently, there's also a third option just to make things nice and confusing, where if you don't want to do 2 years of general internal medicine and you don't want to do a subspecialty, you can continue and just do 1 additional year of internal medicine for a total of 4 years of internal medicine. So anyone who's practicing as a general internist like myself has either done 4 or 5 years of internal medicine residency.
Could you explain kind of like what that 4th year looks like as well? I mean, I don't know which one you did. Did you do the 5-year?
I did 4 years instead of 5, mostly because I was just kind of done with residency by that point.
Yes.
Yeah, it's just residency is hard.
I can't imagine getting to the end of my 3rd year and being like, you know what, I want to sign up for 2 more of this. Like, that sounds amazing.
I mean, there's lots of people that do it. But anyways, nothing against those people that do it. There's a lot of benefits to doing extra training. But for me, I was ready to practice and get out there. So my final year was just spent mostly sharpening skills that I thought I was going to need. I did a couple extra blocks of cardiology because we do a lot of cardiology in the community. I did a few extra blocks of ICU to prepare myself to work potentially in a more rural environment. I did just some general medicine wards and, junior attending, as it's called, some community electives. I feel like I might have done a block of respirology because I barely got any during my core 3 years, and some outpatient stuff as well, which I didn't get a lot of it, which nobody trains very well here.
They don't train outpatient very well in the United States during residency either. We get a lot more outpatient training, but it ended up, a lot of it was nothing similar to what I did when I went into private practice.
Yeah, I mean, I think it's gotten better since I was a resident, and they do more longitudinal clinics over like a year or two where you're seeing patients, a couple of times a month, and you can end up seeing the same patients over again and somewhat simulating what you would do as a real practicing internist, but it's tough. It's tough. So I just did a bunch more rotations, kind of trying to sharpen my skills and get ready for independent practice, and that worked out quite well for me. In the US, the basic core internal medicine training is 3 years.
Mm-hmm. Yeah.
And then you could go out and practice in 3 years.
Yeah. So we sit for the boards after 3 years.
Yeah.
So
that's it. And then you can choose to do more training if you want.
Yeah. So we stayed on, and the Royal College, when we moved up here, the Royal College accepted our chief year because it was more than 50% clinical. So we did quite a few. I mean, we weren't junior attendings. We were just attendings. We were already board certified. And so we were just attendings during that time. And then every week we supervised the outpatient clinics. So we were able to take the Royal College exam. And so for anybody who has done a 4-year residency, because we met those criteria, if you did do a chief year. So in the US, a chief year is in addition to your third year. So you stay on and are a glutton for punishment. Those are the people that like really, really want to torture themselves. Not only do you get all the administrative responsibilities and whatever else, you do get more clinical responsibilities as a little bit lighter, certainly for like a quarter of attending pay and whatever else. But hey, it was great. It was a lot more pay than what we got as a resident. So we were pretty excited about that. But if you do stay on and do that fourth year, and it was more than 50% clinical, that was kind of what the Royal College required for us to be able to sit for the Royal College exam.
That's been the debate in the last several months here. It's because there didn't exist a program here in Canada that had 3 years of internal medicine training. It was kind of unclear how to license all the internists coming from the US, because they weren't technically they didn't meet the criteria.
Yeah, you're not board eligible, here, right?
To write the exam, because they didn't have 4 years of training, but they were kind of in this in between category. So the college, I'm sure you'll talk about this next week, but the college is amending those rules to allow them to considered, practicing internists, because that's where training is, and allow them to bill as internists. Going back to the billing, each section has their own set of fees, but some of those fees are restricted to those individual sections. So, I can't just go start billing for appendectomies and cholecystectomies because I'm not a general surgeon. I also don't plan on doing any of these things, but regardless, these folks, when they came over, were only able to bill as general practitioners, which is also kind of inappropriate because they're not general practitioners. So the college is working on kind of amending all those things.
I mean, that makes a big difference, and I appreciate that everybody's kind of looking into that and addressing that, because it really does make a difference. There's a big pay difference between a general internist and having the general practitioners, I guess.
Yeah, absolutely. I mean, I guess the other thing, just thinking about that, I mean, of course, internists in the United States are not general practitioners, but they also exist in kind of an in-between state, in that the practice here is different than what I understand the practice to be in the United States. So in Canada, internal medicine is 100% a referral-based specialty. We are not a primary care specialty. Well, we don't have any training really in primary care, and we very much are considered to be specialists only. So everyone I see in my outpatient office, and in the hospital, I suppose, is based on a referral. And if you want to see me, you have to have a referring physician, send me a letter and telling me why.
Yeah, that is different. In the US, it is really, so Andrea and I did a traditional internal medicine practice, so that we did primary care, but then we took care of all of our own patients in the hospital and kind of did everything from start to finish, or at least from 18 to finish. And we could kind of get as involved as we wanted to, but everybody who came into the hospital was admitted under us, and we kind of took care of that and then consulted everyone else. That is kind of a dying breed. That's very difficult to do, because it's very difficult to do. There's a lot of long hours, and it's very stressful. And so most of the time now, people are either saying, I want to do outpatient only, or I want to do inpatient only. And, it's been a very long time since I've done any academics in the US, but there are a lot of internal medicine programs that have hospitalist tracks. So in those 3 years, they're inpatient only. And so they are really kind of, getting the referrals from the ER and doing that. So I know that in Canada, 99% of the hospitalists here are general practitioners, and that's a 2-year family medicine residency, right?
Correct.
Is that okay?
So yeah, family medicine here is 2 years. A bunch of them will sometimes do an extra year, in a kind of subset of family medicine. If they want to be mostly in the emergency room, they'll do a year of emergency medicine, or they can do like an extra year in palliative care or something like that. But most of the hospitalists have a 2-year family medicine residency.
Okay. And so in the United States, I would say it's probably 95, 98% plus all the hospitalists are internist. And so that was a very interesting thing for us when we moved up here, and that it took us a while to kind of wrap our head around that, just because it's such a different practice model. It's neither way is good or bad. It was just different, and it took us a long way to figure that out. Now, a lot of the internists are now just being funneled directly to doing only inpatient, and out of that they'll still probably do a lot of them go into subspecialties.
Yeah, I would say most general internists here in Canada will do some inpatient and some outpatient work. Usually it's some combination. I mean, there's certainly some that only do inpatient. There are some that only do outpatient. But I would say the vast majority do some degree of both.
And I think that for me, when I first moved here, I did mostly inpatient only. And my partners, it was because I lived 2 hours away from where I worked. And so it became a real pain. I tried to do clinic, and that just did not work out. So, you drive up, and so it's 2 hours. You drive up, you have a full day of clinic, and then you turn around, you drive back. And that did not go very well. I eventually was just like, yeah, no, I can't do that. So I ended up offering for my partners up there. I was pretty much considered a locums, but I was like a full-time plus and did more inpatient work than anybody else up there. And it was because they were kind enough to see all of my follow-ups. And so when I would discharge somebody from the hospital, I would refer them over to the clinics there and that people had set up. And so that was just kind of the trade-off that I had. Here in Victoria, I admit people get referrals from the ER, get referrals from subspecialty, from the surgeons or whatever else, while I'm doing inpatient work. And then I will follow up with them in the clinic.
2-hour commute each way. I can't even imagine. My clinic is about 3 blocks from the hospital, and my house is about 6 blocks from my clinic. So I walk to work every day. It's a dream, really.
Yeah, that's not bad. It's a pretty nice view that you have. Now, again, it was very pretty. I had a very pretty driving up over the Malahide. I would get to see kind of Vancouver early in the morning, and I get to see Mount Baker, and I get to see the Olympic Mountains on my way back in. But I got very good at spotting bald eagles this time of year. It's amazing for being able to spot all the bald eagles. So
that's awesome. Yeah.
I got to see 3 bears. I still have not seen a moose. I've seen a lot of elk, but I haven't seen a moose yet. So
yeah, well, they're hard to miss. They are enormous.
So that is right, Canada or Americans. I have not seen a moose yet. I have not ridden a moose, and I have still not seen a beaver either. So they're not everywhere.
They're not everywhere, and do not try to ride a moose. The moose will get you. They are very strong.
They seem to be very big.
Yeah,
and I've not seen a grizzly bear. The bears that I've seen have been black bears. So.
Yeah. Fair enough.
You guys have grizzlies over on North Vancouver, right?
We do. Yeah. We have grizzlies there. They're wandering further and further down the mountain in search of food these days. Like I said, we're nestled in the mountains here. It's a beautiful place to live. Lots of lovely wildlife with the occasional bear. So
yeah, and it's not that bears are going around attacking people all the time. So don't worry. You learn how to live with them. I know Jen's like not scared of it, so it's fine. But yeah, I'm not made for that just yet. But I would actually kind of want to see that. I don't know how to deal with Andrea about that, but all right. So sorry about that. All right. So what is your outpatient practice like? How does that work? Because in the US, most of the time, and sorry to cut you off there, but like most of the time, in the US, we have hospital-based practices, which are owned by the hospital so that they kind of take care of all the management of it. So they take care of all the management part of it, and that you kind of contract with them. They do the billing on your behalf for the most part. And then you get paid, you see the patients, you get paid, but you don't have to deal with any of the other stuff that goes along with it. But they're not overly profitable. They're actually not profitable at all, but the hospital gets kind of all the downstream revenues from it. So you send all of your patients to get the labs, get the CTs, get the surgeries and whatever else, which is what makes it profitable. And again, you move all of your patients there. So what is it like here?
Well, I guess it couldn't be more different.
Exactly.
So there are definitely some hospital-based clinics where they let you use the space and they hire the staff and the medical office assistants and do all the scheduling and stuff like that. But I would say most clinics are just in private offices. So like my clinic is shared amongst a bunch of the people in my group at the hospital. We rent space, which has, office space for everybody. We have a group of medical office assistants that do all the scheduling and, arrange phone calls and do that administrative type stuff. And, we bill very much the same way as we bill in the hospital. There's a set of codes and fees that we bill. We submit those to the government through the same little app, and they pay us money. The outpatient fees are slightly higher than the inpatient fees to account for some overhead expenses, because rent and insurance and phone and internet and that kind of stuff. So that ultimately comes out of our pocket, as does staff salaries. But it can be very lucrative. I think people make more working in the office than they do working in the hospital. And by having it that way, we have complete control over our schedule. So if I want to schedule days in the office, I do. If I want to take vacation, then I don't. I had a very wise attending during my residency tell me once that there was no amount of money that could make it worthwhile to book a clinic on a Friday afternoon. And I have very much taken this advice to heart. I've done it a few times in the last few years, and I always regret it. So most of the time, I don't book patients Friday afternoon because I don't have to. So yeah, full control, and it can be quite lucrative even after accounting for the high rents in Vancouver and the surrounding area, and office staff and things like that. Yeah. And then, and the patients are made up of patients that get discharged from the hospital for follow-up, like you said, referrals that you get from the emergency room that don't necessarily need to be admitted, and then referrals from the community, from GPs and from other specialists that are referring you patients.
Is there anything else that we're missing here, or to kind of talking about, about kind of just the logistics of it before we get into the fun part of what is your life like right now? So obviously you walk either 3 or 6 blocks to work, living in North Vancouver.
Mm-hmm.
But what's your life like? I mean, are you on an average week? Are you working 80 to 100 hours a week, or what is your life like? Are you working every week?
No, certainly not. Yeah. My life is variable. From a work perspective, it depends on, how many days I'm on call and am I in the office and all that kind of stuff. But, there's days where I'm not on call and I don't have patients in the office, where I'll go to the hospital and round on some patients and be home by noon. I'll go to the hospital at 9:30 and be home by noon. There's other days where I'm on call where I'll be in the hospital perhaps until 10 p.m. Seeing patients. I am thankfully never in the hospital overnight. I'm lucky enough that that's the way our hospital system works for now. So I do some evenings, but I'm always sleeping in my own bed. And because I can kind of set my schedule in the outpatient world, it's pretty good. I mean, I don't have kids. My wife and I don't have children, so we travel around a lot. My hospital schedule is fairly predictable, so we can plan to do that. And I would say I work somewhere around 35 weeks a year.
I just want to repeat that for the American doctors. He works 35 weeks per year.
Yeah, I would say on a busy year, if I'm taking some extra work and helping out some colleagues, and sometimes I'll go work in the interior to help out a friend of mine. But I would say I never work more than 38 or 40 weeks a year. So that's at minimum 12 to 14 weeks that I take of vacation. And like I said, some of those weeks don't have Fridays because don't book a clinic
because you don't want to.
Yeah. Right. So when I'm not working, I'll be traveling. I'm out on my bike a lot. I've got the mountains are right here, so biking in the mountains. You could be in the mountains and out on the water in the same day. We do a lot of hiking up in the mountains with my wife and I and my dog. And,
for people who've never been to North Vancouver, or maybe never flown into Vancouver, where you fly in and you look and you're like, okay, there's the harbor, and you're like, oh, okay, there's the mountain. How far is it from the ocean to Lionsgate Hospital? What is that, 15 blocks?
Yeah, I mean, you can see the ocean from the hospital for sure. You can walk down to the water in 15 minutes. You could get in the winter, if you're interested in skiing. I don't ski, but if you want to get to a ski hill from my house, it's less than a 20-minute drive to world-class mountains. And yeah, like if I want to get onto a bike trail or something like that, I can hop on my bike at my house and be on a dedicated bike lane, through a forest that's just this gorgeous road in less than 20 minutes. So it really is close to anything. And if you want to get downtown, you can do that pretty quickly. We also have lots of great restaurants and bars and things to do here on the North Shore. There's hiking, there's climbing, there's, windsurfing and all kinds of things, within an hour of here that is super accessible. I tend, if I'm not at work and I'm not out of the country, then I'm outside. It really is an outdoor paradise here.
It definitely is. It's pretty amazing. I know that Jen, if she has like you guys have a different call schedule than I do, but like if she has the afternoon call, I don't know, what does it start at like 2 or something like that, that I know that Jen will sometimes go and she'll go cross country skiing in the morning and then be back in time to start call.
Oh, absolutely. Yeah. I mean, frequently I'll go on my bike before work, and without having to get up at 3:30 in the morning or whatever that triathlete you had on said she was getting up.
Yeah, exactly.
So yeah. It's a bit intense for me, but yeah, I mean, listen, there's busy days. I mean, you're a doctor, you're doing call, like you're in the hospital. Like there are definitely days where I'm in the hospital for 12 hours, but most days are not like that. It's relatively chill, and I still make a pretty good living. I mean, I don't actually know what internists get paid in the United States. I would say most internists working full time are making $500,000-$600,000 a year, and like that's in and around what I make. And again, working 35, 40 weeks a year. I mean, certainly I can make more, but I don't want to work that hard.
And I did want to go back to that. So in the United States, for sure, I think that like the MGMA, which is, I can't remember what it stands for anymore, but that's kind of like the agency that looks at fair salaries for negotiations and things like that. And I was always in the 98th to higher percentile, and I never made anywhere close. I mean, I think the most was maybe a little over $300,000, and that's 47 weeks a year, Monday to Friday, and 6 weekends, and doing kind of all the calls. Like my weekends were better in Nashville. I will say that, like, under that practice, my weekends were better. That's 47 weeks a year.
Yeah, I think I'd go crazy working 47 weeks a year. I mean, obviously I did it as a resident. We all did. I can't imagine. We did 48 weeks a year. We got 4 weeks vacation during residency. I can't imagine going back to that now. Because yeah, I mean, your brain's working. It's a very cerebral specialty, internal medicine. So, maybe it can be physical for sure, but maybe not quite as physical as some of the other ones. But just having your brain on all the time, I mean, it's a challenge. So it's nice to be able to make a living without having to do it. And, before anyone says, but the American dollar is so much more valuable than the Canadian dollar, it's like, that's true. There's no question. And 300,000 American dollars is probably close to 500,000 Canadian dollars.
About 450 right now.
But I'm not spending American dollars. I'm spending Canadian dollars. I'm living in Canada. So.
Yeah, that's what I always say to everybody is that, like, I'm making way more money. And they're like, yeah, but it's Canadian. I'm like, yeah, but I live in Canada. And so that money does go a long way. Mm-hmm. It is expensive. Like, housing is expensive. Some people who are moving up here now, they're trying to figure out, like, whoa, okay, that's really expensive housing, but you make a lot more money. And, just kind of talking about, there's this common misconception that the government, and that maybe this is something that's held over from a long time ago, I don't know, but there's a common misconception that the government kind of limits how much you can make, and that, you make as much money, you make up to this cap, that there's some sort of cap, and you make up to that cap, and then you just like can't work anymore because you can't get paid anymore.
So it did used to be a thing. I don't know when it was a thing. It was certainly before I started practicing, or maybe it never was, and it's just a rumor that I've heard too. But,
you've heard that too.
I know. I believe in the past there was a legitimate cap on your earnings per year, and it was, I believe, different for different specialties. But there was a lot of stories of doctors working 8 or 9 months and then taking the last 3 months of the year off because they weren't going to get paid, or working for free, which, I mean, nobody should ever have to do. So I think it was a thing before, but there is absolutely no cap on services here currently. So if you the beauty of the fee for service system, which is, you have a fee for each individual service you do, is if you work really hard, you get paid more. And if you, are okay with earning a little bit less, then you don't have to work quite as hard. There's much more flexibility in that without being, quote unquote, hired to a job. I mean, if you're part of a group at a hospital, you all have to share in the call responsibilities. But, beyond that, there's a lot of flexibility in what you can do. And there's a lot of reward if you end up, working really hard and seeing a lot more patients.
That is absolutely true. Now, if you're going to pay off your American student loans, which is what I've had to continue to try and do, although mine's not that bad anymore. But yeah, that can be a big problem. But unless, again, don't say, oh, well, it's only US dollars. Like, you're not converting. Like, it's nice if you're going to be an American doctor and you bring your US dollars here to Canada, fantastic. And I know that you're not an accountant and you're not a tax expert here, but everybody would talk about, but you lose it all and you pay so much more in taxes. I mean, yes, I pay more in taxes, I guess, but there are a lot of things, because you're considered an independent contractor. There are a lot of different things that you can do, right? From a tax standpoint, and we don't have to get into all of that. But I found that my effective tax rate here is about 10% higher than what my effective tax rate was in the United States. And that's before I incorporated. I'm still not able to incorporate just yet. There's like a whole lot of being a dual citizen that was kind of a pain, but I'm going to do that next year.
Oh, sweet. Yeah, no. So yes, we pay high taxes in Canada for sure. I mean, I don't think our taxes are higher than certain states like California, which has very high tax, but it's way higher than, Texas or Florida, where there's no state income tax. That said, as an independent contractor, you're right. There's a lot of, and, don't take my tax advice, but there's a lot of expenses you can write off being an independent contractor. Part of, most of us have a home office, which you can write off part of your mortgage expenses and other living expenses, vehicle expenses, your phone, your computer, all those kinds of things, because you're running your own business in effect. Yeah. Most Canadian physicians are also incorporated, where it's actually the professional corporation that makes all the money, and then my Dr. Paul Hertz Incorporated then pays me a salary, which reduces my overall tax burden, because I'm not getting taxed on the entire amount that my corporation is making. That's getting taxed at a corporate tax rate. I'm getting taxed on my personal income, which is substantially less. You can keep the money within the corporation and invest it and grow it that way. It is a challenge for Americans because of the fact that you still have to pay American taxes, and depending on the state, may not recognize the corporation and all that.
A certified accountant,
an international accountant talk about that stuff. Yeah. But for Canadians, my effective tax rate is actually not very high, despite, living here.
Yeah. And I mean, there are other taxes that you have in the US that, you have your paycheck. So you have your health insurance that comes from your provider. I had to pay hundreds of dollars a month, many hundreds of dollars a month for insurance for my 3 kids, because the 3 kids were on my policy. And so that's many, many more hundreds of dollars a month that come out after taxes. And those are things that are included otherwise. And so it's, again, like, it ends up being 6 of one, half a dozen of the other. And once I'm able to incorporate, or once I finally do incorporate and go through the pain of that, it's not going to be a problem at all. It will be much, much better.
Yeah. Not having to pay healthcare, and then never having to worry about co-pays or, big medical bills or deductibles or whatnot. I mean, if I go and see a doctor, I never even consider bringing out my wallet. If you go to the hospital, regardless of what treatment you need, whether that's, a stitch in your foot or open heart surgery, your bill will be $0.
Absolutely. Some of the DME things, like my daughter broke her arm, and so there was like some sort of a cast, and I think that we paid a small fee for a cast.
Sure. Yeah.
It was literally, but I think the small fee was like $22. Yeah. That was $22, and that was the sum total, end all be all of it. And that's the only bill I've ever received. So MRI, CT scans, things that have happened with my kids with all the different injuries that they've had, broken collarbones. My son broke his nose and had to have surgery, and all of that. We never paid a copay, never paid anything, snowboarding accidents, all the things. That is actually one of the things that Americans don't see that as being a tax, but it's a cost. It's a very, very significant cost. Let's say right now, internal medicine, that in British Columbia, and I'm sorry to keep you for so long, but in British Columbia right now is pushing getting internist, family medicine doctors, pediatricians, and psychiatrists, I think, are the kind of the four specialties that they're really kind of pushing in the cognitive specialties, right? What kind of jobs are out there? And we can talk specifically, because I know that you're like, I don't know about family medicine or whatever, but let's talk specifically about what kind of jobs are out there for internal medicine.
I mean, there are tons and tons of internal medicine jobs right now. So again, because everyone's an independent contractor, I mean, anybody could come here as an internist and rent office space and start seeing patients. You don't need anybody's permission to do that. I mean, you need the college's permission for a license.
Right. Once you get a license and once you get a permit to work. Yeah.
And perhaps once the rules change about how you can bill the government, but that should be happening shortly. Anybody can come and open an office and start seeing patients. You just advertise to GPs and other people around. There's an endless amount of work for internal medicine. Internal medicine is an interesting specialty in that I think the more of us there are, the more demand it creates, because of who we are in the healthcare system and the types of patients we see and the value that we bring to the healthcare system and to patients. I think the more people that see us doing that work, the more they're like, oh, these people are actually super useful. I'm going to send more of my patients to them. I think we only see a subset of patients that we could otherwise help. So there's lots of communities that need more outpatient internal medicine. But beyond that, for the people that like inpatient care, or perhaps both, I know that there's quite a few hospitals that are actively recruiting people right now. There's lots of space in hospitals within downtown Vancouver and the Lower Mainland, and certainly in other sites around the province and probably around the country. Again, I think because people are really starting to recognize our value and the good that we bring and the value that we bring to see patients. So my hospital specifically is looking for people. Multiple hospitals in this area are looking for people. So the job market for internal medicine is excellent.
Your hospital specifically, man, how many... so you have like a new tower that has 200 new beds, right? Mm-hmm. And so how many internists are you guys looking for? We can edit this out if you're not ready to submit trade secrets, but you're not in competition with anybody else. So it doesn't matter.
We're all just trying to hire people. I mean, there's job postings right now for 3 new people. I think realistically, we could probably hire 6 or 8. We're looking to expand our service significantly. Our hospital's getting way busier. The region is getting busier, where there's going to be more people in Squamish and Whistler and Pemberton, which are all communities up the highway from here, that our hospital technically covers as our catchment area. We could easily hire 6 or 8 people, honestly.
Wow.
So it's a brand new hospital. It's a wonderful, wonderful place to live. Some would say the most livable city in Canada.
Very large organization who spent a lot of time looking at this.
Yeah, exactly. And we're a super friendly group. And anybody that's interested, I would encourage them to reach out to me, to reach out to other people. I think before making the jump for most internists to work in internal medicine, I would make sure that the college sorts out the rules around billing. It's almost certainly not worth your while to move here and bill as a general practitioner, but it certainly is worth your while to move here and bill as an internist. As the president of the internal medicine group for British Columbia, I'm happy to kind of walk you through that process and explain what would be involved. And as a division head at Lionsgate, I would also be happy to explain.
You're like, I am happy as the president of the SGIM. I am more than happy to funnel you to my hospital first because we've got a lot of work.
But I mean, around the entire province, I mean, it's a beautiful province to live in, whether that's the interior BC, which is a wine region, or the island, which is a gorgeous place, or, the Lower Mainland, and, North Vancouver with the mountains and the ocean. British Columbia really is, I think, the best place in Canada to live. No offense to anywhere else in Canada, but
it is, I will say that it is very incredible. And whatever you're looking for, I mean, if you're looking for something that is bigger, great. You need to look at Vancouver, North Vancouver. You want to look at outdoors stuff, but still being close to an urban city like Victoria, Vancouver Island, you can still get a lot of that. If you want to go somewhere and just work in a very small town and kind of be a huge fish in a small town, like there are those opportunities around. If you want to spend a lot of time skiing, North Vancouver, Kelowna, like all of those places, right? I mean, I haven't been anywhere yet. It's terrible. I've been to North Vancouver a lot, but I have not been to Kelowna yet. I've not been to the interior. Abbotsford is as far east as I've gone. So,
okay. No, the interior is a gorgeous place as well. I know they're actively recruiting people. There's skiing, there's biking, there's hiking, there's wine regions, there's mountains out there as well. Obviously, if there's skiing.
Yeah. I mean, like, to be very clear, there are amazing mountains out there. So again, in North Vancouver, Whistler's an hour away, hour and a half away. Is that right?
Exactly.
So,
Whistler and Squamish is probably, I think, by volume and number of runs, the biggest ski resort in North America, and has absolute world-class skiing. If that didn't
2010
exist,
Olympics.
The 2010 Olympics were here. If that didn't exist, I think people would still come to Vancouver to ski the local mountains, the North Shore Mountains, which, like I said, are 20 minutes from my house. So
in the interior, I know that there's like a bunch of ski resorts just like very, very close to Kelowna, Penticton.
Yeah, exactly. There's Big White, which is near Kelowna, and there's Apex, which is right by Penticton, and there's several others.
You can kind of find whatever it is that you want, and if you want like really hardcore Canadian winter, there is that in British Columbia as well. Like if you there is definitely that available. If you don't, you come to Victoria where there is like no hardcore Canadian winter and it's amazing. But you can still get to great skiing this year. Very, very close. Anyway, any advice for anybody else other than making sure that the college is going to allow you to be able to bill MSP appropriately? Or
so I mean, there's some subtleties to the billing system. There's a subset of internal medicine fee codes that are available to people with that extra training of the 4 and 5 years. So if you've done 4 or more years of internal medicine training, there are the complex codes, which are valued a little bit higher than the standard internal medicine codes, which are going to soon be available to all the people that have done 3 years of training. So there's some subtlety there. Certainly, if you've done 4 or more years, like yourself, Rob, and Andrea, then it's very, very lucrative to come here to British Columbia. Still, I think worthwhile if you've done less than that once the college sorts their things out. So there is a little bit of subtlety there. Yeah, and I can walk you through that process if you need to. There's some complexity to it. Yeah, I would say just think about what you want to do, and if a mixture of inpatient and outpatient sounds good to you and training kind of matches up with that, then come on over. We'd be happy to have you.
Yeah, absolutely. On a day-to-day basis, so just as like day-to-day life. So right now, Canada is in the midst of a big federal election. Election cycles here last 37 days or something like that, which is amazing and a breath of fresh air as opposed to the 4-year election cycles that we have in the US. On a day-to-day basis, how much does politics or political discussions or anything else kind of dominate your life, or political partisanship or anything else? How much does that affect your life on a day-to-day basis?
Almost not at all. I would say now it happens to be the federal election literally in 10 days. So there are people talking about it, but there's no animosity there. People are actually talking about policies. People are talking about what has the current Liberal government done? Do they deserve another term? They switched leaders, obviously, with Trudeau resigning, but are the Conservatives going to be better? And and we have more than 2 parties. So what does the Green Party say? What does the NDP say? So people are talking about that now in kind of an open discourse, but there's no animosity there. People aren't arguing about it. And
people aren't shouting at each other in the doctor's lounge?
No.
Uh,
And outside of this period of 30 days every 4 or 5 years, it doesn't really matter. I mean, we talk about it and it's important, but it doesn't affect our day-to-day life in any capacity. You would almost not know if somebody voted for the Conservatives or the Liberals or the NDP. It's a relatively unimportant detail in our day-to-day life. I think a lot of people over the last few months have been talking about American politics quite a bit.
Quick question. When was the last time you heard a gunshot?
Gunshot. I don't know. I'm trying to think. I mean, I've been to a gun range. I'm trying to think of outside of a gun range, have I heard a gunshot in real life? Yeah, actually, maybe like 2 or 3. I don't think I heard it. There was a gunshot, or there was a shooting. Sorry, there was a shooting in North Vancouver maybe 3 years ago. I don't know if I actually heard the shot or not, but
yeah.
It's certainly not a common occurrence. No.
Okay. So, just in the differences in day-to-day Canadian life, I will say that the threat of violence is drastically different here. That's been one of the things that has been the biggest change for me. And it has been noticeable that there are people have guns here. People have lots of guns here, but there are a lot of rules and there are a lot of regulations, and they're not allowed to carry them around. And you don't hear about shootings. I mean, if there is a shooting, you actually remember that there was a shooting 2 or 3 years ago, 3 years ago in North Vancouver, because it was such a big event.
Yeah, absolutely. I mean, people are allowed to have guns in their homes. People are allowed to transport their guns to a gun range to shoot them should they want to. And you're allowed to hunt in certain circumstances and certain seasons. And, if you have
I mean, like everybody, like you're not allowed to just go around and just like shoot deer all the time in the U.S. either. I mean, like there are hunting seasons, there are licenses, stuff like that. So.
But beyond that, no, people don't carry around. You're not allowed to carry around a gun unless you're like literally transporting it from one place to another where you're allowed to have it. And I would say in terms of safety, I can count on the number of times on one hand, the number of times I felt unsafe being here in BC. Even the quote unquote rough parts of the city, I mean, it's fine. People leave you alone. I mean, sure, things happen, but it's such a safe place to live. I have no qualms walking outside by myself at night, and I don't think about the risk of violence at all.
It's been very, very different. I had a lot of several traumatic experiences. One, my boys and I were in a shooting, in a mass shooting in Mardi Gras in New Orleans. Yeah, I was close enough. I was on a ladder, whatever, with the boys, but I was close enough to where I could see the smoke from the barrel of the gun.
Wow.
And that's there awesome. There were 7 people shot that day, just right beside us. That was very, very traumatic to me. New Orleans was super violent by the time that we left. And, it was getting that way. My oldest son had 2 people in his class murdered. 2 people that he knew, not at school. This was all outside of that.
I mean,
but 2 people.
That's wow. That's unbelievable. Yeah.
And, it just became a way just for the Americans. Like, I no longer walk around places looking to where the exits are. I no longer go into the grocery store, but I was talking with my mother-in-law about this a couple of years ago, of how every time that I would walk into a grocery store or every time that we were in a public place, I knew where, going through the hospital, I knew where the exits were in case somebody started shooting. And maybe that's because I'm paranoid because of what happened to us in New Orleans, or just that it was becoming an unfortunate part of everyday life. And it took me 4 years, but I no longer wear running shoes everywhere I go when I leave the house outside of work. And I no longer do that. But I did that when I was in the US because I never wanted to be in a position where I couldn't run. I am not a hyper paranoid person, although that makes me definitely sound like I'm hyper paranoid. But that was a big moment last summer where I was like, you know what? I can actually wear these shoes, and I don't have to wear running shoes. I don't have to wear shoes that I could run in a pinch.
That is just a wild thought. I mean, I can't imagine you'd meet many Canadians that ever were forced to be in a position to think that way. And it's so unfortunate. I'm so sad that you had these experiences. I'm glad that you no longer do. But
yeah, I mean, it's not that bad things don't happen. They do.
For sure.
But it is very rare. It is very few and far between. And life is not great for everybody here. I understand that. But it's a lot less stress on a day-to-day basis.
Yeah.
I have a lot less stress on a day-to-day basis and a lot less conflict. And there's a lot less anger, I do have to say. Anyway, Paul, I have definitely kept you for a very long time, and I appreciate all of your wisdom and all of your knowledge. But if people want to consider, if people just want to reach out to you and find out a little bit more about internal medicine here, the possibilities of getting a job here, or the possibilities of living and working in North Vancouver, how do they get in touch with you?
You could send me an email or go on my website. I'm pretty sure my website has a contact form on it. I don't use it all that often, but it's drpaulhertz.com. So drpaulhertz.com. And then my email is drpaulhertz@gmail.com. So drpaulhertz@gmail.com, or HERTZ for all of you.
Yeah, I was, we're going to have to throw in a translator at the bottom there, but.
So yeah, just shoot me a message to the website or shoot me an email, and more than happy to chat about things.
Paul, thank you so much for all of your time. I really appreciate it.
Hey, no problem. Thanks for the opportunity to share what it's like to be a doctor in this beautiful place that we have.
Yes, indeed. And we'll definitely have to have you back on, if you don't mind, to tell us all about the other fun and super interesting things that you do when you are not in the hospital and taking care of patients. Thanks. Thank you for listening to another episode of the Interesting MD podcast. Please check out my content on YouTube at Interesting MD, and follow me on TikTok, Blue Sky, Instagram, Threads, and Facebook at The Interesting MD, and on X at Interesting MD. If you have comments or questions and want to get in touch with me or any of my guests, please DM me on socials or email me at rob@interestingmd.com. If you have any ideas for a show and you want to share your hobbies with me, or don't know where to get started on your own project, you can email ideas@interestingmd.com. Please like and subscribe to the podcast and YouTube channel to get the latest content. Much appreciation to Falter Media for editing, producing, and posting all Interesting MD content. Check them out, because if they can do this for me, imagine what they can do for you. See you next week.